So thanks very much for having me, everybody, and thank you, Surrey Place, for dialing in. I guess we'll jump right to it. So I'm going to speak today about mental health problems in individuals with ASD, cover some of what I think is some of the stronger studies looking at estimates of mental health issues in people with ASD, and then I'd like to shift over to talk about what we know in terms of the correlates of those mental health problems. So mental health problems and ASD, it's not necessarily a new conversation. This has been going on for quite a while. I want to highlight the UK's National Autistic Society that recently actually came out with a public awareness campaign around mental health problems in ASD. They really were able to highlight in rather plain language the experiences of anxiety, depression, anger, and attentional difficulties that often go along with ASD, and the costs of those mental health problems for the individual, for their families, and for the larger service system and systems of care. So this is their kind of description you need to know, and it's you can look it up online. It's a wonderful set of videos as well as publications. So what do we know in terms of rates of mental health problems in people with ASD? I'm going to highlight to you community-based studies rather than clinical studies or clinician-referred studies. So it's really important to make that distinction when we're talking about mental health problems and understanding rates, because I could see maybe 400 people in my specialized clinic for mental health problems in ASD, but the rates there are going to be very different because it's a service that's oriented to tackling those problems. The real question when talking about rates, in my opinion, is what are the rates in the general community, at a population level especially. So a number of good studies came out of the UK that I'll highlight here. Tsutsika and others came out with two. The first that I'll mention is one on 5-year-olds. They used a population-based cohort of over 18,000 individuals in the UK, not all with ASD, those the overall population, where they were able to assess through this census hyperactivity, conduct problems, and overall emotional problems, which essentially is a broad spectrum of internalizing issues. And here you can see the rates of clinically significant problems in the general population that they survey. This is through parent report. They also drilled down, and they were able to identify individuals from the general population with an ASD diagnosis, and the confirmed ASD diagnosis, who did not have an intellectual disability. And you can see here the rates. These are of 5-year-olds. So 59% of 5-year-olds with ASD had clinically significant levels of hyperactivity. 38% had clinically significant levels of emotional problems. What's really exciting about this study is that it's one of the first to really differentiate or disentangle autism from intellectual disability when looking at mental health. So here, for example, are the rates of individuals with only intellectual disability, 5-year-olds with only intellectual disability without autism. And finally, if you're a child who's 5 who has both an intellectual disability and an ASD, what the rates are like. So what are the take-home messages here? Well, all three groups, whether you have an intellectual disability alone, intellectual disability and ASD, or only ASD, have significantly greater rates of emotional and attentional difficulties and behavioral difficulties relative to their 5-year-old peers. As well, having an intellectual disability and ASD increases rates, especially in terms of hyperactivity, relative to other individuals with ASD only or intellectual disability. So I think it's an interesting example of where in some cases there are differences, and in others it's really much more broadly speaking about developmental disability and relationships with mental health problems. The same authors did another study with a different cohort, a different population level cohort, looking at 5 to 16-year-olds. And with the same dimensions, with the same scale. So similarly, an extremely large population level. And what they really were able to do is made that same comparison. So you see here rates of that larger, broader group of children and adolescents in the general population that met with clinically significant levels. And now we can see how elevated it gets in terms of ASD alone without intellectual disability, 84% meeting for hyperactivity, 74% meeting for some aspect of clinically significant emotional problems. That, again, is likely speaking about anxiety and depression. And then we see here intellectual disability alone also significantly greater than what you'd expect in the general population. and having an intellectual disability and an autism spectrum disorder. So one of the important messages around this research when looking at a broader age range is that having an ASD increases the likelihood or the risk of having or exhibiting associated mental health conditions up above and beyond having an intellectual disability alone. So, and that increases the risk relative to the general population. So there's an additional effect of having ASD that compounds the issue here. So that's using scales and parent report questionnaires compared to clinically significant or norms. What about if one were to try to apply an adapted set of criteria from something like the DSM, an accepted nosology that we use to diagnose specific mental disorders, let's say? So Siminoff did that. They tried to apply an adapted psychiatric interview to, again, a population-derived sample. So this is only looking at 10 to 14-year-olds with ASD. And of this group, 70% met for at least one associated psychiatric condition, 38% met for 3 or more. And in terms of the most prevailing set of conditions, anxiety disorder, plural, was the largest group, followed by oppositionality, and followed by, again, attentional difficulties or hyperactivity, ADHD. And what's interesting is that of those with ADHD, 4 out of 5 exhibited a secondary diagnosis as well. So comorbidity is incredibly common. If you were trying to apply a psychiatric manual to this, you're likely going to find more than one condition for many individuals that you interview, especially, this is in a population sample, not in a clinic referred sample where people are coming because they need extra care because of their behavioral or emotional issues. So one can imagine how that would compound what you would expect to see. Elspeth Bradley and others here in Ontario did a nice controlled study of adolescents and adults who had autism and severe intellectual disability compared to a matched group in southern Ontario with only severe intellectual disability, and also found a greater number of psychiatric conditions or psychiatric episodes in that population. So ASD again seems to add to if one's already experiencing an intellectual disability. So these are high rates, and comorbidity seems to be something that would be very common. I think anxiety, when we look overall, anxiety seems to be what everybody talks about, but one thing that I want to highlight to you is that there's an incredible degree of overlap or correlation with other presenting symptoms. So the last graph I'll show about this is one that takes that a bit farther, because it says what are the clinical kind of applications of this, and what if we also included subclinical levels? Because many kids that we might see might, for example, exhibit clinically significant or might fit with the specific number of things we need to check off when it comes to, for example, generalized anxiety disorder. But they also might be exhibiting some symptoms of depression, but not enough that they would hit enough of the criteria. Do they not count? Do we not try to understand and adapt our treatments to address that whole child? Of course we do as clinicians. So what about understanding things from both a clinical and subclinical level? So that's what Leifer did, is looked at both clinical and subclinical. You can see along the x-axis, in terms of depression, 10% met for clinical episode of major depression, but an additional 14% had some symptoms of depression but wouldn't have met for that. So overall 24% have some element of that depression. And we can see here how ADHD, how pronounced it is. And then in terms of the rates of different anxiety disorders, how they might overlap, either being like specific phobia, all clinical, or other ones sharing some subclinical aspects as well. Hertig did an interesting study where they invited adolescents with high-functioning ASD, essentially Asperger's or high-functioning autism, to fill out the child behavior checklist and the youth self-report. So the parents filled out the CBCL and the kids filled out the youth self-report. And parents, relative to a comparison group of typically developing adolescents, reported more externalizing and internalizing conditions, and the adolescents themselves reported significantly greater internalizing conditions, but not externalizing conditions, which is not necessarily surprising to me, or to you it shouldn't be if you've sat down with adolescents in general and you ask them, so how often do you break rules and do things that can get you in trouble with others, compared to how often are you feeling anxious or depressed? one might be more likely to endorse the internalizing over externalizing conditions. But the point is that they also had a matched control group. So adolescent to adolescent, the group with ASD was reporting more internalizing issues. So I think that's also, but again, across different aspects: anxiety, depression, withdrawal, not simply anxiety. So I hope part of what we're going to talk about here is that anxiety is very important. I want to talk about that today. But it's not the only aspect to mental health problems. So that's the first shift I'm going to have people do, is when we're talking mental health and when we see or hear anxiety, I think it's important to consider the other aspects of that child's mental health experience. Are they experiencing depression? Are they experiencing attentional issues? Are they experiencing anger and frustration with their environment and their situation? So White did a wonderful review of all the studies specific to anxiety. And as you'd expect, based on the different methodologies and samples that were used, rates vary tremendously, from 11 to 84%. So I like to joke that if you're writing a grant to do anxiety treatments in ASD, you're probably going to be talking about the 84% more. Right? That's probably the higher. Overall, their estimate, their conservative estimate, is probably around 42%, which is very similar, or exactly the same actually, as what Siminoff found when they applied the psychiatric nosology to kids, when they used the psychiatric interview. So that's very interesting. And they proposed, why this variability? What accounts for the variability? Well, maybe differences in IQ, maybe differences in ASD subgroups. Maybe, for example, kids with Asperger's syndrome might demonstrate more than kids with autism. Maybe it has to do with the degree of social impairment. Maybe these are some of the reasons why we're seeing different rates. And they really caution trying to understand rates because of this lack of uniformity, lack of consistent operationalization, as well as the varying degrees of ASD symptom severity and intellectual functioning across studies. So I'm going to now shift the focus to actually looking at, okay, if they've suggested that these might be some of the reasons why some studies might be exhibiting so much anxiety in the findings, let's look at that. Let's see what are the actual studies that have looked at these and how are they correlated with ASD. So what are the correlates of mental health problems in individuals with ASD that we know of? So I'll break this down into our wonderful biopsychosocial component, although really they're considered separate. A lot of these studies examine one aspect or one variable in relation to the dependent variable. So we know that individuals with ASD have more medical conditions compared to the general population, and these might be or tend to be more undiagnosed or undertreated relative to the general population, especially things like gastrointestinal issues, constipation, which has been correlated with anxiety and with sensory overresponsivity in autism. So there is this relationship between some of these gastrointestinal problems and anxiety, as well as a history of epilepsy and higher rates of psychiatric diagnoses in the aforementioned study. You know, I like to stop here and talk about an anecdotal case for a second, and it involves constipation. So that's my warning. I'm going to talk about constipation. And part of my training was in the dual diagnosis program at the Center for Addiction and Mental Health in Toronto, which is partly an inpatient facility for adults with developmental disabilities. And there was a case there that was often described of a young man who was on a number of different psychotropic medications for his behavior. This man was nonverbal, very aggressive, and experienced community breakdown and ended up in the inpatient facility. And one of these things that happens often in a specialized program is, because of the safety there, one can start to peel away some of those aspects of the psychotropic medication to really investigate what's happening, what are the side effects of the medications, and what can we apply behaviorally to help this person's intervention. So this due diligence started to be applied, and through the assessment process, I've been told what ended up happening was they found the person was severely compacted, severely constipated. Right? And perhaps due to some of the side effects of the medications, but regardless, the point was that once they were able to take them off the medications and address this undertreated problem, the person's behavioral disorder, let's say, decreased dramatically. Right? Was it the be-all and end-all for this person? Not necessarily, but it certainly complicates this person's treatment and care. So applying this kind of due diligence to the medical conditions, I think, is a critical component to potentially why we see correlates of mental health issues. There's been one group that, in the pursuit of trying to find genes related to autism, has actually looked at correlates of genes that have been related to anxiety and finding those genes in an ASD population. So I think that's an interesting way to drill down as well. They're looking to see whether there's a genetic component to the actual expression of emotional problems, emotional disorders within the heterogeneity that is autism. I'm a psychologist, so I'm going to shift over to the psychological piece. So what do we know in terms of IQ? Well, across a number of studies, there seems to be often significant but small relations with parent-reported oppositionality in youth, generalized anxiety disorder specifically, anxiety more broadly, and depression. So there seems to be, but again, I want to underscore, we're talking about small correlations. It explains, if anything, a very small amount of the variance. That is higher IQ, demonstrating higher symptom severity in these dimensions. But other studies have also said around hyperactivity, small negative correlations with hyperactivity. So the higher IQ, the less one might exhibit that hyperactivity. And we see some of that when we looked at some of those initial graphs that I showed you that had the ASD only group versus ASD and ID combined, and the high rates of hyperactivity there. So it's a small part of the puzzle. It might be IQ, but it certainly doesn't explain a lot of it. What about adaptive behavior? That is independent skills, right, which is another component too that we often assess. And anxiety is positively related to communication skills, social skills, and activities of daily living. So not impairments in those. The better one's communication, the better one's social skills, the better one's independent living skills, the more likely it is that they'll have anxiety or demonstrates symptoms of anxiety. So it's a positive correlation. But let's get a bit more specific. In fact, when you drill down and you look at IQ differences, that relationship is much more pronounced in populations that we're looking with IQs below 70. So in people with intellectual disability and ASD, adaptive behavior tells a lot more of the story around anxiety than if we're just talking about people with ASD who don't have intellectual disability. Okay, so adaptive behavior might play, it might be an important correlate as well. What about something like negative social comparisons? I'm highlighting here two Google-sponsored Special Olympics collaborations called the R Word. The R Word was a campaign that Special Olympics used to try to get people to stop using the word retard. It's a hurt word, and what they really tried to do is to identify the stigma associated with this. The stigma that clinically, when I do counseling with individuals with ASD or with intellectual disability, I see even today the profound effect that experiencing this stigma can have on their sense of self and how they see others. So I want to highlight this to you because I pulled it many years ago, but you could actually take this tool and apply it to any website, and it will tell you how many times that the R word is used on that website. Right? So for example, on YouTube, at this point in any given day, it had been used 3,700 times on YouTube overall. So this stigma, this use of this term as a hurt term is alive and well. I mean, it's one of the only terms that can still be used on Facebook that's not considered a hurt term. Facebook has all of these things around hate speech and how you can't use other terms because they're terms that denigrate individuals, but you can still use this term on there. So I just bring that up. I'll get off my soapbox for a second and get back to the studies and the science, but I think it's a critical aspect to how people develop and see themselves and prize their differences rather than seeing their differences as issues, and how that might be related to mental health problems. So they did a study looking at, for example, negative social comparisons, where one makes comparisons to other people that are negative. There's two types of negative social comparisons that Headley really talked about. One is downward social comparisons, putting other people down to make yourself feel better. In the end, that might be a short-term way to make yourself feel good, but it actually is related to higher depression levels. The other is seeing yourself lower than other people in terms of negative social comparisons. And one shouldn't surprise you to know that that's also correlated to depression. So negative social comparisons, and that has something to do with stigma and self-evaluation. ASD symptom severity, this is an interesting one. I mentioned before that adaptive behavior and social skills and communication skills seem to be correlated. But when we look at ASD symptoms, so ASD overall as a diagnosis does seem to increase the risk or the likelihood that you'll have a mental health condition. And in some studies, it's positively associated. So in some studies, higher ASD symptom severity, and we find higher rates of mental health conditions. But in other well-controlled studies, we find no relationship with ASD symptom severity, and yet in others, we find only with specific aspects of ASD do we find relationships with mental health problems. So in my mind, when I see this, I see it as equivocal. Right? It really isn't a uniform understanding of those correlates. Let's get even more complex when it comes to understanding and unraveling ASD symptom severity. I'm going to mention this Sokolowski study, really interesting. What they found is an interaction between social impairment that's found in autism and high IQ. So it wasn't one or the other, it was a combination of both. But what really they found in terms of the experiment, if I'll walk you through this, is not experiment, with the relationship, but in individuals with high social impairment, those who are really struggling with ASD social impairment, right? Those with high IQs have the greatest anxiety, right? So high IQ and high social impairment. The individuals who have very high social impairments but with low IQ have significantly less anxiety, right? I think, and those with low social impairments, the IQ differences are really much less pronounced. So one's insight, one can venture that one's insight and one's awareness and one's goals and one's social environment play a part, which come with some aspect of intellectual functioning, play a part in the experience of anxiety and how that relates to ASD symptoms. So let's move on to social vulnerabilities now. I really want to spend some time talking about how social disadvantage has been shown to account for a significant amount of why youth demonstrate mental health problems. Right? A wonderful study by Emerson and Hatton looked at individuals with developmental disabilities and individuals, broadly speaking, or intellectual disability, I'm sorry, and the typical kids, and they found in both groups social disadvantage accounted for considerable amount of variance, more than any of the other variables. I mean, it really is about 50% of the variance could be accounted for by their index of social disadvantage. Right? Now, in autism specifically, Siminoff demonstrated that maternal mental health problems, low socioeconomic status, and family deprivation, so the experience of loss and loss of family resources, is correlated to mental health problems in youth with ASD. And maternal physical health, again, and maternal or parental stress has also been correlated in families of people with ASD. So this speaks to part of the social experience or as a correlate. Interesting in terms of educational environments, specialized classrooms, Siminoff followed youth with ASD over time, over 4 years, and found that being in a specialized classroom, specialized in terms of ASD, led to an improvement in conduct problems for adolescents with ASD. Not improvements in the other aspects of mental health issues, but if they exhibited very high conduct problems, it seemed to be it seemed to demonstrate or account for some of the improvements. So maybe there's a classroom effect that we need to consider. And some of our own work has found correlates in terms of family crisis and in negative life events experienced by the individual and the family. In terms of the other aspect of social vulnerability that I'll talk about is peer relationships. And the ongoing work by Connie Casari and others has highlighted the importance and the challenges around inclusive education. And I think this speaks to the challenges of establishing and maintaining healthy peer relationships for youth with ASD. You know, youth with ASD are less likely to be accepted by peers and experience fewer reciprocal relationships, and this isolation can increase with grade. So, and this is through their following individuals over elementary school. So there's some experience of this that if a child, I suspect, is very aware of this and can really complicate for any child who experiences isolation or being on the fringes and the lack of centrality in terms of peer networks. We know that that's related to mental health conditions. So I think it's important to highlight in this population. And some of our work here, and this is what I presented on when I came here the last time, was around peer victimization, bullying, and how that is also correlated, especially with internalizing mental health conditions in youth with ASD. So that's what what some of the studies are talking about in terms of biological factors, psychological and social factors. I think where I want to shift now is to talking about conceptualizations of mental health problems in this population. I'm going to highlight a few of the challenges around how we talk about mental health problems, and then frame to you, I think, an interesting framework going forward that's more positively oriented. So I've mentioned the word correlates a lot here, and Kasdan and others, Le Cavalier and others, have talked about the challenges of trying to unravel correlates. What are those variables? They're associated, but are these risk factors? Are these true risk factors? Right? Are these antecedent characteristics or experiences or events that actually lead to that mental health problem? Are they really the things that increase that risk? You know, for example, if we modify them, does that change the risk? Right? We don't really know much about that because most of our work has been cross-sectional in nature. This really requires longitudinal designs. Or are those correlates risk markers where we really can't change them? You know, we really can't change somebody's sex, but maybe that's a predisposition that is correlated with outcomes. So I think understanding what are modifiable and what aren't requires both longitudinal and cross-sectional designs and an examination of what's fixed and what's not. And the last part of the correlational puzzle is really the bidirectionality question. Most limitation sections of cross-sectional studies, mine included, mention that these relationships may likely be bidirectional, where they impact each other. And I'm not discounting that as a possibility, as an important possibility. But just recently, there's been some studies that have started to do cross-lag designs where they've actually said, well, what comes first, the chicken or the egg? Let's actually control for one time point, following people at different time points. Tosika recently published a study of 3 to 5-year-olds, so younger children with ASD, and looked at child behavior problems and maternal well-being, maternal stress. And in a nutshell, what she found was that what predicted increases or changes in behavior problems at age 5 was the maternal well-being, which is part of the correlates that I highlighted before. But child behavior problems at the earlier time points didn't predict maternal problems. So actually the maternal problems seemed to actually be leading to the child behavior problems first, which then looped back into being related to more mental health conditions. So I think it's an interesting first step in terms of trying to unravel what really comes first. It's an empirical question that we need to look at. So conceptually, how do we try to wrestle with this idea of ASD symptoms and mental health problems, and ASD in mental health, and mental health in ASD? So Jeffrey Wood and Ken Godow published a really interesting conceptual article, and I'll describe it to you for a second. So they said, okay, individuals with ASD experience ASD-related stressors, that they called, especially 4 broad domains of ASD-related stressors. These stressors are things that happen often, sometimes daily. They're essentially a clash between a person's ASD symptoms and the environment. Okay. So what did they talk about? Well, one is the social confusion, the unpredictability of social encounters that comes with challenges with social cue perception and social awareness, and how that's a stressor in and of itself. Or the peer rejection or victimization that might be experienced because one is acting differently or unable to conform and has a target on their back. Maybe that's another aspect of a stressor often experienced by kids with ASD. Thirdly, you know, the perseveration and the interests, the specialized interests or desires to complete rituals and routines that individuals with ASD have, when they're part of environments that prevent them from doing that, there's a sense of punishment or a sense of loss over being able to engage with that preferred activity. And that's a stressor. And lastly, frequent potentially aversive sensory experiences. Right now, as I'm speaking to you all, and I know it's part of the videotaping, but there's this a glaring light in my face right now, right? For example. And it strikes me, you know, I talk to some of the kids that I counsel when I'm doing therapy, and the first thing I ask them all the time is, do you want me to turn these lights off and turn on the floor lamps instead? And the really assertive kids with prosocial behaviors tell me before they step into the room, these lights are bothering me, please turn them off. Right? Most of the kids don't. Most of the kids suffer in silence and exhibit those difficulties, that stressor in another way. So these are all ASD-related stressors, right? So a pileup of these or a buildup of these can lead to social anxiety, especially the more socially oriented ones, as well as negative affectivity more generally. In this paper, they really focused on anxiety, but they still underscore that this might be also related to depression or anger and frustration, essentially emotional problems related to stressors like this. And I think if any one of us was going through these stressors, it might be more likely that we're experiencing these kinds of mood dysregulation. And then those aspects actually then lead to increased avoidance or withdrawal, right? It can lead to increased ASD symptom severity, so more rigidities, more perseveration, more social or communicative impairments, as well as behavioral problems and personal distress, which then loops back into creating more clashes with the environment. So here we have an articulated cycle of trying to understand how ASD interacts with mental health conditions. Is that fair? So we're dealing with also multiple issues. The high rates of comorbidity found in these studies suggest to us, internalizing and externalizing, they're separate, but they're not necessarily independent from each other. In fact, most of the time, they're correlated. Externalizing symptoms in kids with ASD is often correlated with internalizing issues. So noncompliance, aggressive behavior, irritability, problems with conduct are positively correlated with depression and anxiety. Right? And this is both in terms of self-report as well as parent-report studies. So what do we do with the fact that there's so much overlap, right, in terms of the symptoms? Well, part of it is what came first, even in terms of mental health problems. But the other part is, and this begs the question that was suggested by Barlow and some of his graduate students, including Aaron Reich-May, who's doing some wonderful work around CBT for youth, and now youth with ASD. But really, what are the underlying transdiagnostic mechanisms that explain the presentation of emotional problems in general across internalizing and externalizing conditions? Maybe what we're really talking about here is not what are the causes of anxiety in kids with ASD, but really, given the correlations and the overlap, what are the causes of emotional problems in general that explain both anger, frustration, depression, and anxiety? And this is something that I think we're not having a lot of conversations about when it comes to ASD, but this is something that's actually coming from the general population in terms of the language of trying to understand mental health problems. The idea of what are the transdiagnostic mechanisms? One key one that I'll talk about now is impaired emotion regulation. That regardless of whether we're talking about depression or anxiety, really we're talking about impairments in the ability to regulate one's emotion effectively. So what do I mean by emotion regulation? Well, extrinsic and intrinsic, this is a nice definition. Extrinsic and intrinsic processes responsible for monitoring, evaluating, modifying emotional reactions, especially their intensive and temporal features to accomplish one's goals. Okay, I like that, Thompson's definition. So what does he mean by this? Thompson's definition suggests that emotion regulation can be adaptive or it can be maladaptive. Right? Successfully achieving appropriate affect and not having long-term negative consequences is adaptive emotion regulation. But we can also have maladaptive ones. We all do emotion regulation, and we do it all the time. Right now, everybody's regulating their emotions. Maybe they're upregulating their emotions. They're trying to stay awake in this very fascinating talk. So you're upregulating. Sometimes we need to downregulate our emotions. We depend on our environment for emotion regulation. It's not simply something that's our responsibility internally. It's something that really, especially from an extremely young age, we require on our environment. And it's developmental and it's relational. I was telling Rob before about I have a 2-year-old son, and I see his friends, and he's around, and he's a clumsy kid, and he walks around, and one day he's running, and he falls really hard on his face. Right? And what's the first thing a child that age does after they fall on their face? They look at you if they know you're around. They look at you. And why are they looking at you? Well, partly maybe they're in pain, but they're also looking at you for information about what just happened. Right? And that information that I'm going to provide him is going to be critical to either making him panic and get extremely upset or start to try to calm down and stay in control of things. Right? So he depends on me for emotion regulation and on the environment. So this transdiagnostic process of emotion regulation, Gross and Thompson describe it as 5 modes or 5 temporal elements that I want to briefly talk about here. It starts with situation selection and goes all the way to response modulation. So situation selection. Essentially, the first thing we do if we want to regulate our emotion is we have to know if we can exert control over the situations that we choose to go into. Let's say I'm about to go into a horror movie. Whose choice was it that I went into the horror movie? That's my choice. If I know it's going to scare me too much, I have the choice to stay regulated in my emotions by not going in there, therefore not eliciting the anxiety and the dread that comes with that. Right? The first step in terms of regulating emotion temporally would be choosing what situations. So that can be adaptive or maladaptive. It requires good understanding of the situation and understanding the outcomes, so I know what's going to happen. It requires other people, especially kids. Kids, if I gave my son the option of staying home and watching YouTube for every day, all the day, or going to daycare, well, now he'd choose daycare, but at the beginning, he'd always choose one, but that's not his choice. Parents have a big role to play in situation selection, as well as some experience of choice. But when does this become maladaptive? When one starts to have unrealistic expectations of situations, expecting that that situation's way more dangerous than it actually is. Or when one starts to avoid situations because they've just learned that that's a dangerous situation. Or when one starts to adhere and only go to safe places and safe situations. These are all maladaptive aspects of situation selection. Let's say I have no choice and my friends force me to go to that horror movie. Right? So I'm in the horror movie now, I'm watching it, I didn't really want to be there, but I have no choice. What can I do in that situation to alter the situation? Well, I guess I could leave, I could try to escape from the actual situation, or I could start playing with my phone, or I could start doing whatever else to disrupt the movie, let's say. That would be a way to modify my situation. Right? It's not an adaptive way, it's maladaptive. An adaptive way might be to problem solve in some way. Maybe tell them that I need a break, maybe tell them I can't be in here for this whole time, or tell me when the scary situation is over. So there's adaptive aspects to this, but there's also maladaptive ones. Lots of kids with ASD, for example, are powerful shapers of their environment. Right? Whether it's to escape from something they don't want to be in, or whether it's to create an environment that's imbued with their safety signals. Right? My environment has to be exactly this way, or else I'm going to have an anxiety attack, or else I'm going to get really disruptive. I'm creating a safe environment. I'm modifying my environment for my regulation. Let's say I have no choice over, I can't really modify my environment. What else can I do? Well, in the movie theater, there's one thing I can really do is I can turn my head to the side. I can alter my attention. I can distract myself to regulate my emotions. So it requires emotional awareness. This requires shifting from distressing to non-distressing emotions. Like it's an internal. So now we're no longer trying to adapt the environment, we're trying to adapt our internal experience. But in ASD often, because of the perseveration, because of the over-attention and rumination that can happen, because of the focus on on information that fits with our moods, right, that can really lead us to maladaptive emotion regulation. Let's say I can't really do much attentionally. Well, the next step is to try to change my thoughts about the situation. So this is where CBT really comes in often. But trying to come up with a more reasonable interpretation. So in the movie theater example, what could I say to myself, right, to keep myself in control? There's a few things I could say. This movie's going to own, it's not real. This is almost done, right? I can actually reappraise my situation so that it's not as I don't experience the same amount of fear, right? Or I could say, you know what, I'm here, I'll just live with it, and then it'll be gone soon. I can accept it. A maladaptive approach to cognitive change is to be really rigid in the way we approach the problem, right? Trying again and again in a way that actually fails to find a solution. And a failure to think abstractly about it, to be able to do what I just did. Right? And lots of kids with ASD, because of the rigid thinking, aren't able to do that kind of cognitive control. And lastly, let's say none of that works. Well, now I'm experiencing lots of anxiety. The last thing I can do is try to actually modulate my emotional response. So everybody, when we say emotion regulation, often jumps to deep breathing and relaxation. And that's actually the end of the story, not the beginning. We have 4 options, 4 different classes beforehand where we can regulate successfully. Right? But this is the point where I'm experiencing the dread. Now what am I going to do to actually reduce my physiological arousal? What are the appropriate ways that I can relax? What are the pro-social ways that I can express my emotions? Right? And this requires awareness of the environment. It requires social norms. Right? How many of you watching on TV and here, right, modify the way you speak and how quickly you lose your temper if you're talking with colleagues at work compared to maybe a significant other in your home life, right? The people there matter. They moderate your expression of emotion. Okay? Context matters. But what happens if you're not really aware of context, or if context doesn't matter for you? Then you're missing a potent power of emotional expression, kind of modification. Okay? So I think emotion regulation overall, that's one seed I wanted to plant for you. And the last seed, in the last 5 minutes, is I want to suggest a shift towards mental health. The absence of mental health problems is not the same thing as mental health. Just because I don't have clinically significant levels of anxiety doesn't mean I'm happy. What would describe your mental health? If I said to you, are you mentally healthy? Would you just simply start to talk about the fact that you haven't cried for 2 weeks straight? Or that you don't have a pathological fear of dogs? So that means you're mentally healthy? Or would you talk about other things, like quality of life, like happiness, like experiences of belonging and love? What other language would you use to describe your mental health? And do we talk about treating and caring for individuals with ASD using that language? If we can operationalize that and measure it, then we can actually target that in our interventions. I'm not ruling out the one, I'm suggesting the other. So Richard Lerner's model, Richard Lerner from Tufts University, has a wonderful model of positive youth development, where he says, really what we're shooting for, if we want healthy development, is these desired outcomes. We want kids to experience competence. Once they experience competence, they become more confident. And once they're confident, they reach out into their communities. They reach out into those scary environments. They take those risks that help them stay connected. Once they experience connection and belonging, it helps them develop character and caring to others, and helps them to contribute to their society. These are some of the languages that one could use. But do we really talk about this when we talk about care? What they talk about in this positive youth development model, which I think is very important to consider, is that kids bring with them a whole host of basic abilities and strengths and needs. You know, intellectual functioning, school skills, behavioral issues, emotional maturity, physical health. But that's not enough to lead to these desired outcomes. What do they really need? They need some of those, but they need those to align with very important key ecological strengths, ecological assets. Things like positive people, right? Loving, caring, supportive, safe people, environments and healthy places. So, you know, I mentioned before the social disadvantage correlates. That's what I think that's highlighting here. Okay? We need those positive social environments, opportunities for exploration, opportunities for growth at different ages and different developmental levels. This is a different framework. This is different than just treating, sorry about that, just treating an anxiety disorder. Okay? So I don't really have too much time left to really go. I want to give some time for questions. But here's another way to break down Richard Lerner's model. So you have all these key individual strengths that interact with those assets that I talked about. The positive people, safe places, right? Healthy places, opportunities that lead to positive development. Now you have two options. They've shown in the typical developing literature, if you're low on these C's, so they call them the 5 C's or the 6 C's, if you have a C that you come up with, you can actually add it to the model, as long as it starts with the letter C. Okay? But if you have a lot of these C's, then you can lead to contributions to yourself, contributions to your family, to community, and when you're older, to civic society. If you're low on these C's, you're more likely to exhibit those internalizing and externalizing conditions. So mental health problems still is part of the conversation, but it's just part of a much broader conversation of mental health. Now these things then loop back and impact your ecological assets and your growth of your new strengths, right, over time. So this is a cycle. It's not a static experience. So for example, what does CBT target? Well, you know, technically, CBT is designed to target this tail end. It's designed to target anxiety or internalizing conditions. And we know there's many studies that show that CBT can treat anxiety specifically in kids with ASD. We know that there's only one study that shows it anger, none that have shown it to treat depression, for example. And we know that mindfulness training, for example, Soles of the Feet, has been used to treat aggression in teens with autism, you know, classic autism as well as Asperger's syndrome. But this is targeting this end of the discussion. It's an important part, if that's your job. But maybe your job is to help, maybe you're more focused on social work, and maybe your job is to actually help develop environments that are healthy for the individual. School placements that are the most important outcomes, right? Maybe this is where you're looking at. You're looking at mentorship. You're looking at supportive and accepting schools. Healthy parents. Maybe you're working with parents to make sure that environment is healthier, right? That's a different focus of work. Or maybe your job is to actually imbue skills in the child, keeping the child healthy by accessing medical doctors, teaching intentional self-regulation, goal-directed behavior, using applied behavior analysis to address particular deficits or excesses in the individual child. That's another part of the conversation. You see how every element, I think, has a role to play in supporting mental health. This is developmental, and lots of people know Bronfenbrenner, so this is an adaptation of Bronfenbrenner's kind of multi-systemic or ecological systems theory. But essentially, the child is couched within a much larger system of care. You can find these online a lot. What I think is really interesting is that Health Canada in 2001 highlighted 12 social determinants of health, of physical health. And if you actually go and find those, they're very similar to the correlates that I talked about at the beginning. Okay? So we've known a lot about this for quite a while. We just haven't been talking about it so much when it comes to ASD and mental health. So that's what I was hoping on doing today. So the last thing I'll do is I'll acknowledge all my funders for the chair that you can see here. I have a lot of bosses. This is CIHR-funded chair supported by a number of organizations, including Autism Speaks, Spectrum of Hope, Autism Foundation, Seneve Family Foundation, CASDA, and Health Canada, and York University. So thanks very much, everybody here and at home. I hope you enjoyed this. So thanks very much.